that leads us into the goals of our rehab program, and that's going to be to regain strength and regain symmetry of that strength pattern, first and foremost. Obviously, secondly, we're going to be looking at improving range of motion, except in the case where you've got somebody who's already hypermobile to begin with. At that point in time, we want to focus more on stability than mobility. The last, or should be sort of lower on the priority list, is actually the pain. If we focus on the pain, you're dealing with somebody who's had pain for 20 years in some cases. We want to focus first on getting them stronger, getting them symmetrical, and getting their range back. The pain will decrease, and I tell people that just like with any exercise program, there's going to be some increase early on, whether it be through some delayed onset of muscle soreness, you're activating muscles that have not been used for a while. So, don't be alarmed. That's normal and acceptable. But as with anything, we would be cautious in monitoring those complaints. As we consider the changes and the measures that I'm going to talk about in a second, what we're looking for is 10 percentage point improvement in their neck disability index or more. If we see a 10-point change or more, statistically, we know with 90% confidence that a true change has actually occurred. In Greenwood's study, he found that if somebody had an increase in a limited range of motion of 10 degrees or a 5-pound increase in strength, he saw positive detectable change in his symptomatic group from his study. As we cruise through some of these numbers, and again, we can provide this for you. This is published if you want to take a look at it in more detail. But just to give you an overview, we sampled around 387 subjects. We followed them from a period of 1998 to 2005. During that period in time, we saw that on average, nearly 70% of the patients responded favorably to the treatment being the strengthening. We saw improvement in their neck disability index in the 47 to 60% range. And these were people who had, on average, had neck pain for almost 10 years, 4 years, and 3 years. How long does the program take? We break it down and we look at it. Actually, these are three different patient classifications: private insurance, auto insurance, and work comp. What we saw here is that the people on the private insurance, on average, took 18 visits in order to get better. Whereas the auto insurance, on average, took about 20, and the work comp took around 27. Now, what does that mean? When we talk about the length of time, I tell people it takes between 18 and 27 visits, on average, for us to see a positive or significant change with your client. Within that time frame, we're seeing range of motion improvements in the 20s and 30% range. Again, these are based off of people who have range of motion limitation or asymmetry. But the key measure is over here, and these numbers are a little bit small, even for me to see at a distance. And that is that, on average, we see approximately 100% improvement in their strength gain during that time. So the correlation there is that if we get them moving and we get them stronger, we're making them better, or helping them to get better. And that's going to be, on average, 7 out of 10 people who have been suffering from chronic neck pain. As we followed those same group of people for a period of 2.5 years, we found that, on average, they continued to improve even 2.5 years after the discontinuation of therapy. So average NDIs that started, up in the 40 and 50 point range, they reduced to 20 at the point of discharge, but even 2.5 years later, they saw another 25% decrease, down here to 15.2. Symptom intensity rating, which is a visual analog scale that is rating the symptoms, hence the name, whether it be through nausea, pain, numbness, tingling, headaches, all of those different types of symptoms that commonly go with the neck pain. We see that, on average, they saw a 20 to 25% reduction as well over that 2.5-year time span. So it takes us back to the goals of rehab. Our goal is primarily to regain strength. We need to improve the range of motion. which is going to help improve function. But the first goal in that, Sue was going to address this with her clients, is taking first a manual therapy approach to make sure that we've got everything moving correctly the way that it should, and then we'll address the spine. So we want to correct pathomechanics before we begin to address significant weakness. When we do that, we have a study that was published by Lauren Harding back in 2006, where she tracked the outcomes of patients as well. And what she found was that after 9 visits, if somebody had a 7-point improvement in that neck disability index score, so 3 times a week for 3 weeks, on average, a 93.2% success rate in predicting that that patient would fall into that 7 out of 10 category. So the concept of predictability of an outcome is a pretty powerful tool that the MCU has to offer. Whereas if we see somebody who's regressing, so exercise is actually making them worse. So in this case, we would see a 7-point decrease in their neck disability index. So again, as I said, that's usually going to be your degenerative disc population or your stenosis population. Those with severe arthritis, they can actually be, their condition can be somewhat exacerbated with the exercise. In that particular scenario, we have nearly a 70% accuracy in saying, you know what, the MCU is probably not the right course of action for you at this time. And that's at a point where we refer them either to more of a long-term conservative care or sending them back to their physician for further workup. So again, pretty powerful numbers right there. At this time, I'm going to turn things over to Sue. Sue's going to present 3 of her clients, all ranging from a short-term, 2-3 years of pain and discomfort to a subject with up to 20 years. So Sue, at this time, I'll let you go ahead and take it from here.
Thanks. Can everyone hear me?
They're muted, actually, so if they can't,
okay. You can hear me. So.
They'll be texting into Brian if there's any problems.
Yeah, chat.
All right. The first case that I'm going to talk about is a 37-year-old female that I saw just after I had my MCU. So this was a few years ago. And she had a motor vehicle accident 11 years prior to me seeing her, which was pretty significant in her life. She was pretty debilitated. She was out of work. She had severe vertigo, walked with a cane, and she basically was unable to be left home alone. Her mother-in-law was staying with her because she was just so kind of out of it. And she had suffered this chronic neck pain for years, and no one was able to really help her. She had normal findings on her x-rays and MRIs, and she had undergone several treatments, including injections and chiropractic manipulations, and I think she underwent just about every type of physical therapy out there. And she was referred to me by our surgeon that I work with, and I took a look at her and I thought that the MCU might be the best outcome at this point because she had every other treatment under the sun. So I started her on the MCU, and will I advance this, or are you going to advance it?
I advanced it.
Oh, there we go.
I advanced it.
And thanks. And after 26 visits, if you saw her radiograph before, she made significant improvement. She decreased her disability rating by 33%. Her symptoms improved by 83%. Her strength by 75%, and her range of motion by 25%. Her headaches were gone, her vertigo was gone, and she was able to walk independently. And she actually returned to a part-time job. So she was a great success. And after living for that many years without any relief, after 15 weeks, she made significant progress. So without the MCU, I don't think I could have accomplished that.